everyone for joining us back for another interesting presentation. This time we have Ilona with us, and she's working with the supervisor of Mamika from the Brown University, and she has an interesting topic for us today. It's on cancer therapeutics again, but she's taking a very different perspective in a prototyping way. I'll leave the platform out for her. Yeah, please go ahead.
So good afternoon, everybody. My name is Ilona O'Keefe. Before I begin, I'd just like to thank CCIR for giving me the opportunity to present here, especially because my project has shifted significantly from the original abstract that I had submitted. So as you might see on the timetable, the titles don't exactly align. I had a few issues with my previous paper, so I decided to start again. However, I'm not completely finished with this new paper, but I've definitely made enough progress to be able to present here, so I definitely appreciate the flexibility and support. With that said, the paper that I'm currently working on is titled Leveraging Tumor Marker Environment Shifts for Cancer Relapse Monitoring. So firstly, I'd like to just quickly start with going over what the current clinical protocol actually is when it comes to relapse monitoring and why it might not be ideal. So right now, when a cancer patient is in remission, typically every 3 to 6 months, depending on the type of cancer, there'll be some sort of clinical exam and blood tests, and then every 6 to 12 months, there'll be some sort of imaging, such as like a CT scan or an MRI scan. And these checkups will usually continue for a couple of years, and then they'll start getting more and more spread out until there's no more need for them. However, if an indeterminate lesion is detected, which means it's not clearly benign or malignant, so it doesn't meet the criteria for an immediate biopsy, then what usually happens is that it'll just be monitored for another 3 to 6 months, and then there'll be another rescan. However, obviously the issue here is that during this 3 to 6 month wait, you're essentially blind as to what's going on at the molecular level within the body. So this lesion, it could be progressing, it could be regressing, or it could be stable, except you don't really know until your next scan. So as a result, having these fixed spread out checkups might not be ideal because, if you take, for example, a person with a regressing lesion, if they had real-time insight into the tumor or lesion's activity during this wait, well, maybe they could have avoided unnecessary following-up imaging so soon, and that could have minimized cost, stress, and clinical burden. But also, same goes for the other way around. For someone with a progressing lesion, it might have been nicer to catch a cancer a little bit earlier. So this is where the tumor marker environment comes in. So this image might be a little bit confusing at first, but I'll try break it down. So put simply, it just illustrates how a solid tumor progresses from this pre-invasive stage all the way eventually to intravasion and then metastasis. However, importantly, this image actually illustrates which molecules allow the tumor to progress at these different stages because, of course, your body is not just going to ignore a big clump of proliferating cells. It's either going to stop them from spreading or sometimes malfunction and allow them to spread, which is how a cancer will evolve. So for example, right here in your top left corner, you have your pre-invasive tumor, and this is usually the category that indeterminate lesions will fall into. So although your CT scan or MRI scan might just show a clump of cells, as you can see, there's actually a lot more going on at the molecular level within the tumor microenvironment, and this could give you really good hints as to whether your body is managing this tumor well, or it's letting it, unfortunately, progress into a cancer. So although I can't really go over all of these precise processes, eventually what does happen if the tumor marker environment does become more permissive is that your tumor will start progressing into this invasive stage, and here it'll begin to breach the baseline membrane, which is just right here, and then it'll be officially classified as malignant. So this whole dynamic process, although it is invisible to us externally, it could be going on between scans, which is why monitoring the tumor marker environment could be so critical. But also what's important to note is that in order for all of these little molecules to move, as you can see here, your cytokines or chemokines, well, they need to somehow move through this tissue, which is what this kind of like blank peach canvas is at the back. So what tissue is made up of is 3 main components. You have your cells, your extracellular matrix, which is kind of like just these proteins such as your collagen, which kind of holds it all together, and your interstitial fluid. So what interstitial fluid is, it's just basically the liquid that fills the space between your cells and your extracellular matrix, and it acts as the medium through which all of these molecules can diffuse and communicate. However, depending on the size of the molecule, the ease at which it can diffuse will vary. So for your little small molecules such as glucose and lactate, they're under 3 kilodaltons in size, so they're very light. It'll be easy for them to diffuse and kind of flow around the fluid. So they'll be found in relatively high concentrations within your interstitial fluid. And that's kind of why your CGM patches work so well for diabetics, because obviously glucose is in high concentration. When you get a little bit bigger, around 3 to 70 kilodaltons in size, it will start to get a bit more tricky for these molecules to diffuse, but they'll still be relatively light and they'll still be found in high concentrations within the interstitial fluid. The issue usually comes with these molecules that are above 70 kilodaltons, so like your antibodies, they will be a lot heavier. So they'll usually have kind of their own methods of moving around the tissue. For example, one way which this can be done is that they'll temporarily bind to components of your extracellular matrix, for example, collagen, and kind of like crawl their way up, essentially. But what's great about the interstitial fluid is that, you know, since it's very abundant, it's in your tissue, it can be accessed quite simply in a minimally invasive way. And one way in which this can be done is via your microneedle patches. So what microneedle patches are, they're just arrays of micron scale needles that painlessly penetrate the stratum corneum, which is just like the top layer of your skin. It's avascular, it doesn't have any nerve endings, so it's not very painful to penetrate it. And in this way you can access your interstitial fluid. So you have different types of needles. So you can have hollow ones, which can just like collect interstitial fluid and analyze it externally. You can have solid ones with sensors built around it, so they can directly sense biomolecules in situ. And then you can even have newer ones, which are porous, and they will directly secrete directly secrete treatment into the interstitial fluid. So knowing this technology exists, I came up with a bit of an idea, which is essentially what my paper proposes. So first he proposes a new clinical concept, which is the real-time tracking of tumor microenvironment dynamics to assess cancer relapse. But as well as that, it explains how this can be relatively simply and feasibly done with current established biosensing technologies, such as your microneedle patches. So how did I go about this? First, I did have to go through a bit of a marker selection process, because as you saw in the image before, many different molecules are involved in cancer progression. So I began by just compiling them into a table, and the first thing I had to do was actually figure out which ones had a relevant and significant role in the tumor microenvironment. So what do I exactly mean by relevant? So I wanted to prioritize the markers that were mostly involved in the processes that occur just before or as invasion begins. So I excluded those that were mostly involved in tumor initiation or late-stage intubation, because obviously the goal here is to figure out when a lesion is becoming cancerous, not when it's only starting to form or when it's already spread. Also, I didn't want them to be significant because, you know, not all of these markers have equal contributions to tumor growth. Some of them are more impactful than others. So as you can see, I just briefly grouped them into what their actual function was and then what their phase was. As well, I did want these markers to be detectable in the interstitial fluid. So I did prioritize extracellular ones, and preferably ones under 70 kilodaltons in size. Although, of course, you could measure intracellular markers via maybe certain metabolites they secrete. That would just get a little bit more difficult. So just to avoid that, I decided to stick to extracellular markers. Also, I wanted them to be clinically validated and actually have clinical proof of being linked to cancer. So after going through all of that, I was able to kind of cut my list down to 10 significant molecules. And obviously the next step was to realize which ones were feasible to detect with current microneedle technology. This is definitely where it did get a little bit tricky, because some of these markers that are just so important for cancer progression, they're really difficult to detect with current technology. For example, down here, lysyl oxidase and MMP9. These are two enzymes which are crucial for extracellular matrix remodeling, and this basically allows your cancer to cross the baseline membrane and essentially become invasive and dangerous. However, since these are enzymes, they can be secreted in two forms. So you have your active form and you have your inactive form. However, they're very similar, so it's kind of hard to distinguish them. But since only your active form actually causes damage, if you do measure both of them, you might get a bit of like a skewed idea as to what's actually going on in the body. As well as that, I did want the concentration of the marker not falling short of 1 picogram per milliliter within the body. Because current studies show that microneedles, they tend to have a limit of detection at around 1 picogram per milliliter. Also, I didn't want my final list to preferably not exceed 5 markers, as the highest number of biomarkers simultaneously detected by current microneedle technology is 5. Also, I want them to have validated aptamers available for biorecognition. So what exactly do I mean by that? Since microneedles themselves are a subtype of biosensor, they function by the same core principles that any other biosensor would. So how they work is that you have your analyte, which in my case would be some sort of molecule, some maybe checkpoint inhibitor, and then you have your bioreceptor, which actually recognizes this analyte, and then your transducer, which transduces this into a quantifiable electrical signal. So since most of the markers I'd mentioned earlier, they were proteins, they do have validated antibodies available for detection. However, the big issue with all these organic sensors, such as your antibodies, your enzymes, your nucleic acids, is that they're not very stable. So they degrade quite easily, especially in heat or in harsh conditions, as well as that they can be quite expensive to produce and purify. And since the microneedle patch that I envision would be one that's actually capable of maintaining biosensing stability for long-term use, I did want to make sure that there were synthetic receptors available, as these tend to be stable, more smaller, and a lot more cheaper. And this is the category that aptamers fall under. So although there's many other synthetic receptors and they have their own benefits, for example, molecularly imprinted polymers, they tend to be the most stable out of them all. I did decide that aptamers would have been the most ideal in my case because they tend to be really good at recognizing complex molecules and larger molecules. And as well as that, they work good with electrochemical transduction, which is the best type of transducer for microneedle patches aimed at longer sustainable usage. So before I move on, just to quickly explain what aptamers actually are, they're basically just these synthetic short strands of DNA or RNA, and they can be immobilized on top of an electrode with a little redox tag attached to the other side. So when they bind to the target molecule that they were designed for, they'll change shape, and this redox tag will either move closer or further from the electrode, and that will cause a change in current and generate a measurable electrochemical signal. So of course you can get these synthetic receptors produced from scratch, but just for the sake of convenience, I did want to kind of prioritize those ones that had available ones already. So after having gone through all of that, I was able to kind of get a final list of 5 markers that together were able to provide a good picture of whether a tumour was progressing or not. However, I did want to preface, I just added an optional interleukin-6 or CXCL12 depending on the context, because I do think it's important to keep the panel modular. I don't think it's good to keep it really strict because, depending on the context of the tumour or the person, they can be kind of swapped around or changed just to increase specificity. So although I don't really have time to go over all of these markers in detail, and it'll take me, and it might get a little bit boring, I will just go over through one of them to give you a bit of an example. So VEGF-A, vascular endothelial growth factor A. What this is, it's a principal driver of angiogenesis, and angiogenesis is just a fancy name to how tumours get their own blood supply. And this is essential for a tumour if it wants to grow past like 2 millimeters in size, because it's how they get their oxygen and their nutrients. And what it does, how it works, it's basically just secreted by certain cells in your tumour microenvironment, for example, your tumour-associated macrophages, and then it'll just bind to the corresponding receptor, the VEGF or A receptor, on an epithelial cell, and that'll just kind of stimulate the epithelial cell to proliferate and start forming blood vessels around the tumour. So as I mentioned, I did want these to be clinically validated. So VEGF-A has been studied for a very long time, as you can see, since 2000. So what Smith et al. Showed in 2000 is that VEGF-positive tumours in patients with oral and oropharyngeal squamous cell carcinomas were more likely to recur locally with a relative risk of 3.08 and a confidence interval between 1.03 and 9.24. So what this basically just means is that the positive VEGF-positive tumours were 3 times more likely to reoccur locally in comparison with the control group, which would have been the VEGF-negative tumours, and they were 95% confident that this was somewhere in between 1 and 9 times more likely. As well as that, they were more likely to reoccur distantly with, again, a high relative risk. And also VEGF positivity was the most significant predictor of poor disease-free survival and overall survival. So as you can see, it is definitely a significant molecule and it's been studied for a long time. And then in terms of its detectability in interstitial fluid, it's under 38 kilodaltons in size, so it's quite small, and it is secreted extracellularly. And also in 2021, Yao et al. Showed that the baseline serum VEGF-A levels were significantly higher in small cell lung cancer patients than in control groups, with the mean value being around 145 picograms per milliliter. However, I do want to preface that this is baseline serum levels. So as you know, I'm looking at measuring the levels in interstitial fluid. And this kind of brings me on to certain challenges that I had to consider. So firstly, as I just said, detection thresholds. The majority of these biomarkers, the concentration at which they're considered elevated and abnormal is based on serum, which is just the liquid part of your blood, and not on interstitial fluid. And you know, if you think about it logically, since your interstitial fluid is right beside your tumor, biomarker concentrations are going to be a lot higher here than in diluted blood samples. So this does make it difficult to set precise clinical cutoff points, and that is something that would have to be established and calibrated, as well as that specificity. So by themselves, these markers aren't all perfect, and they can be elevated due to various other reasons, for example, a fever. So in order to avoid false positives, it would definitely be important to incorporate external data. For example, you know, the normal amount by which interleukin-6 would be expected to rise during a fever, in order, you know, to stop every single immune risk causing a relapse scare for cancer, because that would not be great. This is also why using a wider range of markers is better, because it gives you more of like a holistic view, but that can cause like issues with technology, as you know, too many markers can introduce signal noise, complicate data processing, and just reduce overall accuracy. So finding a good balance there is important, as well as that baseline variability. So patients in remission, just like any other human, are going to have varying baseline levels of markers, and some sort of factors such as the type of treatment they received or comorbid conditions can affect this greatly. So for example, obesity or radiation therapy, they can cause an increased level of pro-inflammatory cytokines. So of course, in order to address this, it'd be great to establish personalized baselines using patient-specific data and then kind of incorporating that into the system. And then machine learning could maybe help training machine learning models on this to be able to take into account all these various confounders, and also sensor stability. So over time, these sensors, they can be coded with the molecules and become less precise over time. So this is called biofouling. So anti-biofouling compounds can help with this, but also this is why I think that designing single-use patches that are kind of replaced on a regular basis, for example, weekly or bi-weekly, could help tackle this. So kind of in the same way that your CGM patches work for diabetics, which is kind of where I got my idea from. However, I do need to still evaluate the cost of this. So as I mentioned, I'm not finished with my paper yet. So I'll definitely be looking into how much all of this costs to kind of find the right, I guess, middle ground. So once I do finalize my paper and determine the optimal way to, you know, manage all of these challenges, what the envisioned impact would be is that these patients in remission could wear these patches and then have their tumor microenvironment marker profiles tracked automatically. And this could safely enable earlier intervention for lesions showing molecular progression, or delay unnecessary imaging for stable cases. Moreover, I do want to say that one really important aspect of this is that it could definitely help by providing psychological reassurance, because especially for people in remission from cancer, obviously it can be quite stressful knowing that you're predisposed you know, to developing certain cancers, and having an indeterminate lesion can be quite stressful. So that is something really important to consider. As well as that, this does work better for a specific subset of cancers. So firstly, cancers that are accessible via the skin. Of course, this would not work for hematological cancers or a glioblastoma, for example. It would be better for accessible ones via the skin. And it's also better for aggressive cancers, such as triple-negative breast cancer. Because, you know, the rate at which a tumor moves from this pre-invasive stage to invasion does vary. So in triple-negative breast cancer, that can happen in under 2 months, whereas in some other slower cancers, like low-grade ductal carcinoma in situ, this can take like 5 to 10 years. So definitely this wouldn't be kind of aimed at that demographic. But even with that said, I still think that it's good to know that this isn't only limited to people in relapse, although they are more vulnerable. This could definitely just help anyone with an indeterminate lesion by providing a bit of a safe net, I guess. But anyway, whatever context this is utilized in, I just think that the concept of moving away from passive observation to active molecular surveillance is what truly matters. And that's my presentation. Thank you very much.
Thank you very much. It was super interesting and super informative. Do we have any questions from the audience? Please go ahead.
Yeah, so You mentioned there are like 5 or 6 markers for your detection. I was just wondering, does your sensor use the same mechanism? As you mentioned, it's like a redox?
Oh yeah, so basically, there's many different types of like transduction you can use. What essentially happens at the sensor, they can be coated with this like kind of like electrode, and then the aptamer is attached on top of the electrode with the redox tag. So that's kind of how, or did I get your question correct? Sorry.
Yeah, so I was wondering, so like your one sensor could detect.
Oh no, sorry. Oh yeah, I forgot to actually mention that. No, so essentially microneedle patches, they're just like multiple arrays. So you can have different rows, and then one row could be for one sensor, one row could be for another biomarker, and like so on. And usually it can fit up to like 10 rows of these microneedles. No worries.
Give us a list of, in the table there also proposes of transducers and other things. Can I ask you, are they consumable? Do you have to change the active electrode or something once in a while?
Yeah, so the transductor, like the electrochemical one, they don't last too long. So this is why I did mention that kind of making patches that you could replace would be best, because then, you know, calibration drifts can occur over time and all of that, and then the sensor will be less accurate. So that's why I definitely want to look into cost and actually see how long these can last and whether it's like something that's affordable even.
Please go ahead.
So, a very exciting idea. I think that it's clear your rationale for this is very well thought out. But the practicality, of course, remains to be established. And I'm wondering how much research is there to show, so you're going to put this patch like on the arm, which could be very far away from a solid tumor, somewhere in the lung or the liver or whatever.
Of course.
So is there enough literature to give you an idea about how far these cytokines or VEGF or PD-L1, how far do they migrate through the body? Because most people are looking at blood, and there it's clear that it migrates all the time.
Yeah. Well, I'm not too sure. Like, I was kind of thinking this when I was imagining this. I was kind of thinking of like breast cancers or melanomas, which like where the tumor would be like quite near the skin, so the microneedle would be really close. I still, I don't actually know how far the tumor would have to be from the actual microneedle patch. So that's something I would definitely want to kind of establish before I publish this, to kind of see what distance it can go into the body, and to kind of get a bit more of a list as to what cancers this could be useful for. But so far I just do know that it would definitely work for like your breast cancers or your melanomas, but I definitely do have to kind of see how far these do travel through the fluid.
So how do you think that could be tested?
I'm not too sure. I would look through literature maybe to see if there's any information on that, but I'm not really sure if that could be tested without like actually lab work online.
I think it could be tested with a mouse model.
Oh yeah, like actually doing
in the mouse.
Yeah.
You shave the mouse and you put the sensor at different distances from the tumor.
But yeah, if that's something that isn't established currently in data, then definitely like lab work would be needed. But I'm kind of just like writing my paper so far based off what is available data online. So.
Do you think it's a possibility that exists a data set of cancer people, cancer hospital, they take regular blood test, and we have the blood sample data? It might not be public. Do you think that exists?
Oh yeah, I have looked at some data sets, and a lot of them aren't public, and they do need permission. So that's definitely something to consider.
But
kind of getting.
Might have such data.
Yeah, possibly. I don't know. It's really hard to access data because obviously privacy issues and ethicality. But
But I can definitely see the next steps ahead, because it's more useful rather than having one blood test every week. If you have a monitoring full time, even though the threshold of catching it is low, like you mentioned 1 pg per millimole. If you monitor, it's slightly better than once a week, I think. The idea is super cool. I'll leave to the next question.
I'm an endocrinologist, so I do deal with diabetes and CGMs, and my area of expertise is thyroid cancer. So it's a very, very interesting idea. The only thing is VEGF inhibitors and PD-L1 inhibitors are gaining popularity now in areas of thyroid cancer. But those levels are not measured right now. So I think the challenge would be to find out how much the levels are. I mean, currently it is not being measured even in the serum.
Yeah.
So we just use it based on the pathology report. And so I think the first step would be to find out the levels in the interstitial fluid and see if it correlates the one in the
Of
serum.
course.
And when these medications are used, to see how those levels correlate.
Yeah. That's kind of why I did put it into the challenges, because I think that is really important, because obviously right now we only know the kind of levels at which they exist in serum when there's a cancer versus when there's no cancer. So definitely, like, we don't really know as to how much they're just being secreted naturally, which would definitely be important to kind of collect data on that.
Any more questions? Please go ahead.
I think it's really impressive how you were able to adapt your presentation in a really short amount of time.
Thank you.
Can you explain why your original plan didn't really work out, and what inspired you to follow a new direction?
So my original plan was mostly focused on lung cancer and kind of doing another type of wearable, but there was new papers published in 2025, and I don't know, they didn't exactly match up with my idea. Although it could have been a challenge to consider, it's just kind of hard to meaningfully pursue an idea when you're not as confident in it anymore. So I just kind of wanted to start again completely, because I do find it difficult to stick with something unless I actually kind of really enjoy the idea. So I was kind of always doing something looking into cancer. So before I was kind of looking also into some CAR T therapies. So I kind of knew that I was going to look into something to do with cancer, so I didn't shift too far from that in that sort of sense.
Any final questions? If not, thank you so much for the presentation today.
Thank you.